Right. Good evening, ladies and gentlemen. Thank you for still staying with us in this second Malaysia ECG Summit. I'm Tian. I'm from the Sarawak Heart Center, and I've been giving the theme of Thor in action. So I have 3 cases with some ECGs, and we will proceed on with some Q&A in between, and finally about management and a little bit of a discussion about each cases. So without further ado, let's go to the first case. So we have here a young 33-year-old gentleman, but quite off the bat, he has a structural heart disease. He really has severe mitral regurg, and which a repair and angioplasty was done quite some years ago. It's really a known case of AF, and he came in with palpitations and exertional dyspnea for a week to a separate hospital before finally being referred to us in our center. So on presentation, he was just tachycardic, BP was fine, and ECG, well, no brainers there. It's basically atrial fibrillation with a rapid ventricular response. You can see a PVC there. PVC highlighted right here, but this is your fast AF, in other words. So can I have the Slido? It's a quick one. If you were seeing this patient at the point of time, how would you treat this patient? So we just do a quick one and to see whoever can answer. Thank you. Last responses. So quite a fair bit. People say for this fast AF, IV digoxin. Well, it's not wrong. Some oral beta blockers, amiodarone quite a bit. Just less than a quarter. Some even went to cardiovert. Well, okay, where to cite. So what was given? Yeah, the audience did guess right. Most of the time, most patients with a stable BP, with structural heart, we would do give IV digoxin. However, in this case, it was given, but the rate was too fast. So amiodarone was then loaded and continued over a day. Unfortunately, 2 days later in the previous hospital, he was still in fast AF, despite being on beta blockers and even oral digoxin. So they loaded him again with another bout of amiodarone. And when they saw this ECG, he's still fast AF, no wonder the treating physician decided to give a second bout of amiodarone. And just to continue the story, he was inevitably cardioverted because despite 2 bolus of amiodarone, AV nodal agents in between, he still remained in fast AF, so he was DC cardioverted. As you can see here, the ECG highlighted here on the right panel shows that he's back in sinus rhythm already. So we thought, well and done. So we took him over to our center for further management because he was considered an unstable or very fast rhythm that required DC cardioversion to see how we may help him. So when he came over, yeah, sinus rhythm rate is not too bad. Maybe those keen-eyed observers or those with sharp eyes may notice something a little bit off about this ECG already, but let us discuss further. So what's next? Bear in mind this ECG that you're looking at. What will you do? Can I have the next slide, please? So will you do nothing? You just, something that we perhaps missed that we give rise to is incessant tachycardia. Anticoagulate, because if there is severe MR with atrial fibrillation, we like to do echo, perhaps the structural heart worsen, or since he came to our center, we have EP services. We would like us to consider ablation for this young gentleman with fast AF. So let us look at the results. Yeah, good. Most of them want to see what's wrong with the heart. Something deteriorate, the EF got poor, MR return. Some people want to check the electrolytes. Fair enough. Ablation, yes, certainly we can offer later. Anticoagulation, some may do nothing, which is not entirely wrong because you have treated the symptoms and he's more or less stable now. So unfortunately, this happened. The nurse who called you to attend this patient in the ward, shortly after he transferred over, he had LOC, he lost consciousness suddenly. Fortunately, he was connected to a cardiac monitor, was on continuous telemetry, and it showed this very bizarre looking tachycardia. So you don't need to stay too long, it's clearly something abnormal. So what do you think has happened? So let us look. So fortunately, after he was resuscitated, we had the chance to look back at the initiating event. So let's focus what's happening here. There was maybe some normal rhythm before he went into this unstable tachycardia. So after looking at this strip, we can have the next Slido. We have a few options here. So what do you think has happened? This is quite commonplace scenario, quite a commonplace referral point. Whether whether I mean the Slido is on. Slido. Whether we think there's some form of monomorphic VT second to ACS, some ischemic event triggered this off. Something else triggered your suspicion that why suddenly he came over. Just about under 1 day he was quite well. Suddenly LOC required actually defibrillation. So we have about 30 plus response. I think that's fine. So we think that maybe he has ACS. So all right, fair enough. Common things are common, but quite a fair bit things, something else apart from the choices that was given here has happened to him. Very good. So let's go on. So let's take a closer look. Let's digest this telemetry. The answers are actually there. So he is in sinus rhythm here. There's a sinus beat there. That weird looking beat is probably a PAC, followed by another sinus rhythm, followed by yet another sinus rhythm. It's clearly a broad complex, so it's PVC. It's a bit early. So, but if you want to really hone in on this ECG, that highlighted in the clippers there is the QT interval. Looks a bit prolonged because the PVC is coming quite dangerously close to the T wave. So what happened in this beat, sinus beat? PVC hit there, and it's very near the T wave, which trigger off torsade. So it is a form of polymorphic VT, likely because the PVC hit too close to the T wave in a setting of someone with prolonged QT already, which trigger off polymorphic VT, or when there's a polymorphic VT in the setting of prolonged QT, is called torsade depot, TDP. So likely due to a amiodarone. So if you look back at the history and what has happened, and in fact, if you go back go back to the first ECG when he came to our center, this already shows quite obvious of a broad inverted T wave in your precordial leads with clearly a prolonged QT. You don't even need to count, you can eyeball, it's longer than the RR interval, so there's prolonged QT. Right, so we got our answer. So how will you manage this patient? Can I get the next slide, please? We want to give yet another amiodarone. If you think that it's not done enough damage, we like to supplement with some magnesium sulfate. We consider lignocaine, seeing that amiodarone maybe has done some harm, or we want to give another bout of digoxin, seeing that it maybe partially worked or did not work in the first place. So we have 30 plus answers. Very good. Most of us would like to give some MAC-SAF after we have resuscitated or did our ACRS. So he was defibrillated clearly and returned to sinus rhythm. We did give MAC-SAF, amiodarone was then withheld, but unfortunately, despite magnesium sulfate stabilizing in our CCU, he still developed bouts of polymorphic VT due to very prolonged QT. And bear in mind, he actually escaped CPR, as it was witnessed quick and swift defibrillation could be administered. So in the end, we had to give lignocaine infusion. First was a slow bolus of 100 milligrams, and we then gave a continuous infusion with the dose stated over 1 day. At the same time, while lignocaine was going in, we did give continuous infusion of magnesium sulfate, aiming for a rather high magnesium level of 2.0 or even more. So we were very glad that just after 1 day of lignocaine, his rhythm more or less stabilized, and after 2 to 3 days of continuous IVI magnesium supplementation, he was stable. As you can see, his QTC beautifully narrowed down to 463 milliseconds, and we were quite happy. Now, of course, those who actually selected echocardiogram, you're right, we would require an echocardiogram, and this just basically shows that his EF was slightly down, and there was a return of the mitral regurgitation, and it is definitely still need to rule out ischemic cause, so we did bring him in for a coronary angiogram, which anyway, the 2 loops here simply shows that his coronary angiogram for both left and right coronary systems are quite normal. So perhaps this is actually tachycardia-induced cardiomyopathy. He was quite well discharged with bisoprolol, and we did plan for an AF ablation in the future. So now, just going into a little bit about discussion pertaining to this patient. So this is from the latest ESC guidelines published just at the ESC Congress this year with regards to ventricular arrhythmias and how we deal with it. So I'm going to zoom in. Kelly came in some form of electrical storm because it was recurrent torsade. So of course, bring it down the process. In all cases, if the patient is unstable, you need to administer advanced life support, including cardiovascular and defibrillation. And of course, you need to consider sedation, as sympathetic overdrive would just continue the vicious cycles of ventricular arrhythmia. And then you look at the ventricular arrhythmia type once you have administered life-saving protocol. And in this case, it's polymorphic ventricular arrhythmia, polymorphic VT, as we pointed out. Now, practically wise, there are only usually two main types of causes of polymorphic VT, or torsade if there's not VT. So circled in blue is acute ischemia. So you're not entirely wrong if you think of ACS, because that's a very common cause of a polymorphic VT. And of course, in this case was acquired long QT. And you can see ESC guidelines have clearly said remove the precipitating factors, which is amiodarone in this case. Correct electrolytes pertaining to magnesium and potassium. You may consider isoprenaline, pacing, and of course for recurrent VA, there is deep sedation and intubation, which we won't get to, but let me bring you into this quite nice diagram. It was the result of us dealing with the pandemic, COVID, and perhaps giving some QT prolonging drugs that the authors of this paper come up with a nice diagram how to minimize the risk of torsade. Torsade by drugs that is able to prolong the QTC. So in this patient, the patient already has torsade, and the QT was clearly longer than 500 milliseconds. So first things first, we aim for magnesium more than 2, potassium more than 4, and consider continuous supplementation of magnesium sulfate. That fails to work, like in our patient, we need to consider lignocaine with the doses as said there, with of course monitoring hepatic function. And if the heart rate is a bit bradycardic, well, not too brady, but the cutoff point is, let's say, less than 80, we consider either pacing or even inotropes such as epinephrine, dobutamine, or if you have it in your place, isoprenaline to increase the heart rate to more than 80. As we know, by increasing the heart rate, you're actually able to shorten the QT interval. So in a nutshell, this is the rough algorithm how we approach patients who have unfortunately suffer from torsade due to long QT, be it acquired phase or even congenital long QT. But that's beyond the scope of our talk today. So that's it. And just to highlight, anyway, this paper was from way back in 1986. I put this in just to put on a take-home message that amiodarone is, even though it's one of the most commonly used antiarrhythmics in all centers in Malaysia, in fact, from district to tertiary, owing to the fact that it is efficacious, and it's also one of the last few options that we can use for patients with structural heart disease. But even back in '86, they already identified that it's able to cause ventricular fibrillation or polymorphic VT due to its QT prolonging side effect. So this from up to date. Must not forget, and we always be cautious of prolonged QT whenever you administer amiodarone. Now, don't get me wrong, it is not the aim of this case presentation to caution everyone against the use of amiodarone. We use it all the time. It's just that when we use it, sometimes we always forget, or during to ward situations, patient dose, etc., to actually check the ECG after we've given at least a bolus dose, or at least after we've given infusion of amiodarone, what is the QT interval, as it's a very common cause of acquired long QT. So let us move on to our second case. It's a bit shorter. So we have a 30-year-old lady. Pre-morbid, she's quite well. Unfortunately, she was referred to us for recurrent syncopal attacks. Primary physicians seem to think that it could be cardiogenic in cause after ruling out other causes. And the initial workup, as suspected here, was normal. It means history, physical examination, blood investigation was normal. Last syncopal attack was associated with chest discomfort. Plate here, her echo was otherwise normal, and this is her resting 12-lead ECG. Now, some of you may say that, oh, maybe there is some abnormalities which could indicate ischemia, perhaps. The SA segments in the inferior looks a bit flat. Some, perhaps I would say non-specific T-wave inversions, but certainly, normal axis, I don't see any pre-excitation, nothing too worrying at first glance. So, can I have the next slide though? I'd like to ask the audience, what we will do next if you face with such a situation. Young lady, recurrent syncope, maybe some chest is the last one. Echo normal, history and physical examination normal, basic blood investigations normal. quite a common referral in, I would say, from your primary health care clinics up to specialist clinics also would see quite a lot of these referrals. So we have nearly 40 people, so that's good. So we will do a Holter. Oh, yes, very good. That's a quite good non-invasive way to quantify what's happening over 24 hours. Some will actually do an exercise stress test, which is a good consideration, and some may even, if budget allows them, will put an ILR, so very good. At least none of us would like to reassure this patient without further investigation. So that's reassuring in itself. So we did do a Holter, but I didn't show because there's nothing exciting, no arrhythmia detected. So we proceeded with a exercise stress test. The one chest discomfort, associated with it. So why not? See whether there's any symptoms related to stress. So looking at the pre-exercise ECG, mind you, this is before she actually started running. We are actually gifted with a potential clue of what could be happening. So it's otherwise sinus rhythm, yes, but if you can see that, PVC start to occur. I mean, there's no price to guess what is it. It looks like a PVC over here. There's an inferior axis in your inferior leads. It's coming out here. In fact, you get 3 beats during this ECG just before she started running. So nonetheless, we find something. Hey, maybe something's up. Considered, we proceed to ask her to run. So at stage 1, just half a minute into running, you can see rhythm starting to get a bit interesting. Let us leave the comments till later. So I'll let you take in this ECG. Heart rate did go up quite fast to 100. BP was fine. She was otherwise feeling fine. So at towards the end of stage 1, not even stage 2 or 3, heart rate did go up quite fast. ECG seems to be a bit chaotic. Our friendly technician who was supervising the test grew worried. This could be some chaotic rhythm, which may degenerate to something quite sinister. We do not know yet. And up to stage 2, when we find this bizarre looking, now you can say it's a tachycardia. My new patient was quite well. She just felt a little bit of palpitation, not the same thing that she felt previously. No chest discomfort, at least at this point of time. So our technician thought that enough is enough. They've elicited something clearly abnormal, so we stopped the test. And then this was an ECG during recovery. Yes, some sinus rhythm in between, but still some funny bits in between. So we'll go into the discussion after this, but let me ask you, the audience, through our Slido, what could it be? And looking at the ECG with the most number of bizarre looking complexes, I would be interested to hear or see what thoughts you might have. All right, the polls are coming in. Okay, we are 30 something. I think it's fine. Let's see the results. It's quite a fair bit, so it's split about a third, just under a third, just more than a little over a third is symptomatic PVCs. Some of you think could be pre-excited AF. Well, it's a very good diagnosis to consider. Some people, at least just under 20%, think it could be VT. Well, why not? So, okay, let's go through the ECGs one by one. So this is normal one. You don't see anything much, except for the non-specific T-wave inversion, which I mentioned. And this is the one where she started exercising. So yes, these are actually PVCs. Some of you who actually chose pre-excited AF, you may not, I get what you're trying to say, because some complexes, such as this, may have looked like, there's a bit of a delta wave there, a bit slurred onset of the QRS complex. So it's a good differential to have. But really, all these are actually mainly PVCs. So when she ran faster, now notice, PVCs, if a young lady, echo looks okay, unlikely to have ischemic heart disease from history and risk factors. If they have PVCs, usually most commonly is outflow tract PVCs, and usually there should be only in one morphology. But you can see one predominantly negative looking PVC here, under one predominantly looking positive PVC here. So what I'm trying to say that the PVC looks to be going in 2 directions, and when she's running this fast, you can hardly see any sinus beat in between here. So it's just like, multiple salvos of PVCs, and when you get PVCs that are coming non-stop, you actually get ventricular tachycardia because it's a ventricular rhythm in tachy. So this is what we call bidirectional ventricular tachycardia. So this ECG is, this exercise stresses is a quite nice illustration of how we elicited a bit of a rare case of bidirectional VT. Now, some of you may already think bidirectional VT, there are only so few differential diagnoses that we can elicit. And in our center, we are able to send genetic testing, and she tested to be positive for CPVT, or it's quite a long name, catecholaminergic polymorphic ventricular tachycardia, which is actually an autosomal recessive. There's dominant and recessive, but she got an autosomal recessive type of CPVT. Now this book is quite a good basic book, but anyway, from textbook, we already know that classically, bidirectional VT is usually caused by either ditch toxicity or CPVT. In this case, we have proven without a doubt from genetic study that she has CPVT. Now, once again, taking from the latest ESC guidelines on how we deal with ventricular arrhythmias, and there's a chapter on CPVT from ESC 2022. For this patient, she has bidirectional VT, and she has probably arrhythmic syncope. So general recommendations are quite easy. Avoid exercise. Unfortunately, they have to avoid exercise because clearly the exercise stress has elicited the VT out. And beta blockers, which is quite easy to prescribe. And then we'll assess her during follow-up. If it's still symptomatic, you can try flecainide, but unfortunately that's only class 2A, or there's still further syncope or documented VT. You may consider ICD, or LCSD, stands for left cardiac sympathetic denervation, which is done by our cardiothoracic surgeons. So anyway, this is a flow of management for a patient with CPVT, and that's actually how we approach her. But glad to say, in real life, she was doing well with just general advice to avoid stress, many physical exertion to avoid that, and also she's symptoms are more or less controlled on beta blockers alone. Now we are going on to our last case. So we have a middle-aged, quite young lady, actually, no comorbids. She came to with palpitations. With this ECG and, mind you, a stable blood pressure. So if you look at this ECG, definitely if you look at this ECG, definitely something in sinus, a tachycardic rhythm. And can I get the Slido, please? What will we do next? If you look at this ECG, oh sorry. All right. So quite a fair bit will give adenosine. Well, that's fine. So let's look at this ECG. So at first glance, I'm sure most of you will be thinking of some sort of SVT. It looks narrow-ish, complex, definitely tachycardic. May not be able to make out the P waves or not, but so let us dive deeper. What was given actually verapamil? Because clearly the physician treating the patient with this tachycardia actually had an underlying thought on what it could really be. So if you can notice here, the axis actually changed. There are T wave inversion not really seen during the tachycardia. So let's discuss more about this ECG. So this is the ECG during tachycardia. So notice in the inferior leads that is actually negative. So it's negative, whereas the ECG during sinus rhythm is actually positive in the inferior lead. So axis has changed. And V1 and V2 is not really that narrow. It actually looks broadish. If you compare to the ECG during sinus rhythm, clearly it's a narrow QRS during sinus rhythm. So is it truly a narrow complex tachycardia? I think not. If you count properly here, it's actually more than 120 milliseconds, and it displays a right bundle branch block pattern of tachycardia. So could it really be normal, your normal SVT, AVNRT, AVRT? Perhaps not, if I pointed out these few features to you. So let's think again. What is the likely diagnosis again in this patient? Can I get a Slido? Maybe 30, polars. I think we can close to both. So every time after I pointed out those features were not really salient, but some features everyone think it could be something else. 20% still think it's some form of SVT. The rest of them still feel that it could be some form of SVT, AVNRT, JT, or even AVRT, or even AT. So let's go on to the next slide. Okay, so if you think at this diagram of the heart, looking at the axes on our ECGs, so this highlighted in red is the left posterior fascicle of the left bundle branch. That highlighted in orange or yellow, that's the left anterior fascicle. So anything or tachycardia arising from the left posterior fascicle will give rise to a left anterior fascicular block-like pattern. So if the tachycardia is coming from there, it will give rise to initially a upstroke in negative in your inferior leads, positive R in 2, 3, and finally because it depolarizes the bulk of the myocardium later on when it goes up as in a left anterior fascicular block type pattern. That's why you get a deep S wave in your inferior leads. And in AVL, because it's traveling towards the direction of AVL, if you follow the yellow arrow, so you get a positive deflection in AVL. And V1 shows the RBBB pattern because generally most tachycardia coming from the left ventricle will give rise to a RBBB-like pattern, generally speaking. So anything arising from the ventricle, so this is a form of a fascicular VT, we think. So that's the explanation. So we are treating this patient as a left posterior fascicular VT, resembling someone with a left anterior fascicular block. And if you look, one more feature to think about the ECG in sinus rhythm. So if you notice here, there are these, some folks may say, hey, could it be indicative of some form of ischemic process undergoing? Because there's quite a lot of T wave inversions here. Well, these are simply memory T waves. It just signifies that the ventricle was previously depolarized in abnormal fashion. Previously. So you can see this in patients who were actually V-paced for some time, then they return back to sinus rhythm because they were being paced abnormal depolarization in the ventricle. So when they go back to their own intrinsic rhythm, you get memory T waves. You can see that in some cases of Wu Parkinson White, or you can see that in patients who were having VT, and when you revert back them to sinus rhythm because the ventricles were being activated abnormally, when they go back to sinus rhythm, the memory T waves persist. So a rough guide would be where the R wave, where the QRS complex was negative, the T wave actually did follow. So some of them remain negative. So treatment based on guidelines would be, of course, so this is one of your quite classical verapamil sensitive type of VT, which she did respond quite well to verapamil, and you can maintain them on chronic treatment on oral verapamil. But perhaps even higher class of recommendation for treatment would be catheter ablation. For this lady, she was maintained on oral verapamil, and the plan was actually for ablation if she still was symptomatic. She wasn't too keen on invasive therapy to begin with. So I think that's all for my 3 cases. I'm a couple of minutes early, but I think that's just right.